Good morning. Welcome to today's show. Today we are talking about cognitive decline. Specifically, we're going to examine in more detail what is cognitive decline, how do you detect it, how do you prevent it, how do you treat it, and what documents you should have in place to protect yourself and your family if you might be facing cognitive decline. I'm Jeff Rehmeyer. I'm an attorney and president of the CJ Law Firm. Historically, my practice has involved business, real estate, and estate planning. Now, I'm emphasizing a focus on estate planning to include planning for young adults. On today's show, we again have Dr. Michael Spangler. Welcome back, Doctor.
Glad to be back.
This is your fourth episode, and the prior three have been outstanding. The reviews have been great. I mentioned that to you before, so I'm looking forward to today. Today's topic is one that's been requested by people who have watched the show in the past, which is why I asked the doctor back. For those of you who are new to Dr. Spangler, he is the Vice President of Medical Affairs at UPMC Pinnacle Memorial Hospital. He's had a long and successful career at that hospital and its predecessor in our community. Dr. Spangler has a Bachelor of Science, a Doctor of Osteopathic Medicine, and a Master's in Healthcare Administration. So previously, Doctor, we did talk about the Advanced Healthcare Directive, including the Healthcare Power of Attorney and the Living Will. We also spoke about organ donation, and individuals watching your prior episodes have requested this topic. So let's start by you telling us exactly what is cognitive decline.
All right. There's a couple things when we talk about a definition of cognitive decline. The first of which is there is a very fine line between two main things in medicine. One of them called cognitive decline or dementia, whatever we want to call that. And then the second of which being delirium, which is in medical school, those are the big two that we're actually deciding between. As far as definitions are concerned, let's start with delirium because that's the easier one. Delirium is basically defined as a change in mental status that is potentially reversible. Mental status meaning where we are in the world and how we relate to things around us. So, for instance, I don't know if you've ever had a family member, call it an aging family member if you wish, that ends up with some kind of infection. Let's be honest, in our aging women population, the most common is probably a urinary tract infection. And what you see is they start getting more and more confused. As a matter of fact, some families get them on such a regular basis that they say, hey, you know what? She's acting a little bit weird at this point in time. I bet it's because she has a urinary tract infection. The issue here is we start seeing that confusion, but in the case of a urinary tract infection, we can give an antibiotic. The antibiotic takes care of the infection and the mental status goes back to baseline, okay? Which means you don't have any long-term lingering effects from that infection. This can happen literally with any type of infection for sure. Things like pneumonias, things like COVID can cause these reversible altered mental status, okay? Now, in medicine, when we look at this, the differential diagnosis or the number of things that can cause delirium is endlessly long. The reason why it's important to know this is before we start saying somebody has a cognitive decline, we need to identify that there's not one of these reversible causes of confusion first, okay? So that's in its old bucket. So you go to your family doctor or you come to the hospital because somebody's really confused. We need to work really hard at trying to identify it's not this, it's not this, it's not this, okay? Now let's swing it the opposite direction, cognitive decline. The amazing thing about cognitive decline is it really can happen at any age. There's a number of different things that can happen. We were talking earlier, there's a word called senility, which people use a lot. It's not one of my favorites, but really what it says is people have an aging brain. Whether that aging starts at age 45 or whether that age starts at 105, the body is probably programmed to have some kind of a backward trend in the cognitive function. Now, we all know a couple of things that really kind of outline what we picture as true cognitive decline. The one that everybody's aware of is Alzheimer's type dementia. Again, the body has has a steady decline that it can be early onset, it can be late onset, but we start kind of losing that ability to process, to get through information. What people don't know is it's not restricted to just Alzheimer's type dementia. There's something called multi-infarct dementia, which can act exactly like that. There's Pick's disease. There's several different things that fall into that world of organic reasons why our ability to process slowly declines. Now, one of the most important things to identify in cognitive decline is early identification of it. There are very limited things we can do once people get to what we would term end stage cognitive decline or end stage dementia, because unfortunately damage is done or decompensation has occurred. If we start picking up things early, and when I say early, it can be as simple as, hey, you know what? I've been losing my keys lately. Certain names of people that I normally used to remember just don't come up as early anymore. Especially things like I met a new person maybe yesterday or the day before, and I can't recollect their name. Those are warning signs that something's happening. Now, don't get me wrong, we all do those things, right?
I'm going to say, you just had me on alert.
Yeah, we all do those things. Trust me. Like I said, I have a great story with my kids. We were down in Disney one time and we completely lost where the car was. And we were walking out there until I think the place emptied out till we finally found our car. Not those kind of things. This is more of a repetitive nature of things, right? So okay, we lose our keys at one point in time, but most of us, or hopefully most of us, if we start losing our keys, we start getting smart to the point where, hey, when I get home, I put my keys at the same place every time. And I go back to that spot. And if they're not there, now I'm in trouble. If you start forgetting to put your keys there, or you're putting them all over that house in kind of a sporadic way, again, weird, right? There are phone numbers, like you have a phone number of let's say your daughter that you call 5 times a week that you talk to her. All of a sudden now you're not remembering that number. It's getting harder and harder, and you don't know where to go to get that number. Those are those warning signals. Then what should happen is well, first thing is the people who recognize this the most and the earliest is not the patient themselves. Normally it's the loved ones of those patients, whether it's somebody that's with them all the time, like a loved one, a spouse, or the kids pick it up a lot and say, hey, you know what, we're noticing a difference there. And then the trick is, don't just sit on it. Go see the family doctor. Start describing those things that we think are happening, because typically the patient themselves have a tremendous amount of denial that this is going on in the first place. Okay, you don't want to get to the point where your aging father is now in a car and forgets where he's going and ends up 5 counties away and lost, and somebody finds him. You don't want to get to that point. So identifying it early and making sure that the primary care physician is aware of the concerns that everybody has. Okay. Then what happens is you go into their office and they start doing things. They start doing cognitive testing as far as the MOCA scale and some of these other things that you can do. That is just a exercise in responding to a certain amount of questions. For instance, they'll give you 3 common things like a pencil and a book and your cell phone. And then you're supposed to remember those things. Then you talk about something else and they return to them later. And it's all on a point scale as far as, okay, is this normal or is this not normal? And then people may understand that in one of those scales, you have a clock and you draw a time on the clock. Now, not digital, obviously, it has to be with hands, but and the new generation, I'm not sure necessarily knows how to do that all the time. But all of these go into an algorithm that says, is this concerning to me for some type of dementia process or some type of cognitive decline that's happening? The reason why that's important is we can do a lot more early than we can late. We were just talking earlier. What about different diets? What about medications that we can give? And all of that has probably about the same efficacy, which means it works about the same. We have a couple medicines out there. Aricept and Namenda are the two that are most popular that we prescribe as far as prescriptions. And again, it's not meant to reverse dementia, because dementia in itself, by definition that we talked about earlier, delirium can be reversed. Dementia does not get reversed, but it can possibly prolong or delay the progression of cognitive change that the patient may have. There's over-the-counter medications that claim to do so. There's many vitamins that people see over the counter that you can take. And like I said, I'm not against using any of them. What I am against is doing them on your own. You should have a provider or a doctor or a nurse practitioner that is following along the course of it. You need to be letting them know what the medication or the over-the-counter is that you're using, because sometimes as we get older, you start finding that it's not just a patient that's on one of these medications. They're on 3 or 4 different medications, and then we need to be careful about drug-drug interactions that can be potentially dangerous for the patient. And like I said, the very astute clinician, then every time you go in, or maybe not every time, maybe twice a year, then repeats that cognitive test. And by numbers, you can see, are we having a decline or are we staying about the same? And that's really important as well, because when do you go from, okay, I'm trying these over-the-counter measures, doc, now we need to start trying to take medications for it. And the doctor can then say, okay, well, we had a decline of X number of points. Let's go ahead and try something different, rather than simply repeating the same thing that doesn't seem to be working. I know I talked a good bit there. Any questions from that?
Well, just to do a short recap. So the dementia delirium distinction, delirium is a short-term condition, perhaps caused by something else,
right,
that can be reversed if you address the underlying issue.
Right.
So when somebody comes in showing some sort of decline, that's step one, is to make sure that they don't have something that's creating this delirium as a byproduct.
Right.
Once you get to dementia, then that's something that you want to keep an eye on, or perhaps more importantly, you want to keep an eye on for your loved ones, because you may see it in them before they see it themselves.
Right.
And then what I heard your recommendation to be is to get with the right healthcare provider, and that creates an opportunity to measure what dementia may be in place or not. And then that allows the opportunity to start looking at different treatments that are used in conjunction with the measurements, so you can see what is or is not effective. And those treatments essentially would delay the onset of dementia, which could start at any time, not any time, but you would give it a range 45 or something like that to 100. So
right,
if you're less fortunate, it starts early. If you're more fortunate, perhaps it starts late. But typically it's, for everybody, it's going to arise at some point. It's just whether something else gives out first, or you're around long enough for your brain to start to have these issues.
Right. Exactly. And one of the scariest things is, I mean, we don't have a real great answer why, but it does seem like these days there's more and more of these younger people that are having these problems. That early onset Alzheimer's disease is devastating. Can be very, very difficult both on the patient and the family that's involved. Because bear in mind, people don't die of dementia. People don't die of cognitive decline. They die of whatever their comorbid condition is, whether they have heart disease or something else that gets compounded or occurs. And it can be devastating to a family. You have somebody in their 40s that starts to have that change and that confusion. It becomes very, very significant.
So if we just back in a little bit, so in terms of prevention, you alluded to diet, and I mentioned to you prior to our start that I'd looked at a magazine that recommended what I would call a Mediterranean style diet that included nuts, berries, whole grains.
Mm-hmm.
That sort of thing potentially can be helpful.
Yep, I'm a big fan in kind of that holistic look for patients' care for sure. Like I said, can I tell you one fad diet for it over another? I can't, unfortunately. The data isn't strong enough to say this one versus another one. One of the things we do know, and just to segue a little bit into the problem we're having with infant formulas and things these days, is that there are certain like free fatty acids and things that function in omega-3s that people talk about, that early on in the development of a baby figures in brain and cognitive development as well. So my guess would be there's probably a diet that's rich in those free fatty acids. Mediterranean diet is one of those that actually will probably help more than something that like an Atkins diet, which not an Atkins, bad example, but a diet that would eliminate a lot of those fats from you, because chances are those fats are actually going to be beneficial for cognitive decline as well. Like I said, I wish I had the magic recipe. Unfortunately, I do not have it. But that combined with challenging the mind, I think, is the big thing, right?
Mm-hmm.
You have, let's give an example. So you have somebody who loses their life partner at age 75, and that with that life partner, what they used to do is be out and about and be very gregarious in the community and go out and do things. All of a sudden now they're at home. They're not seeking those relationships with other people. They're watching the television and not really kind of challenging the mind at things. I'm convinced you'll find that progression would be a little bit faster on them. Do I have great data on that? No, but I'm convinced that occurs. And in those situations, what we should do is really kind of encourage them. Yeah, they need to get out and about and all those kind of things, which is easier said than done, but at least challenge the mind. It's simple things like getting crossword puzzles if they're into that, or something to really kind of challenge them, get back into reading things and discussing that reading with somebody. In the world of the internet, there's a lot of that stuff available. I mean, don't read the stuff that's not very good as far as accurate information, but at the same time, continue to challenge the brain, because just like we know, if you're laying in a bed for a period of time and not using your muscles, your muscle mass will go down. Same thing happens in the brain. If you're not actively engaging parts of your brain, hopefully every day, it's not as sharp as it used to be, and that will assist with or aid with that decline rather than trying to prevent it from occurring.
Okay, so diet potentially helpful,
Yep.
and then you said activities.
Yep.
Beyond merely watching TV. So social activities,
Yep.
clubs,
Yep.
Reading. You said reading and discussing. So that sort of interaction where you're verbalizing.
Right.
You also mentioned puzzles as well.
Yep.
Okay. How about exercise? What about bowling or pickleball or strength training or walking?
Yeah, I think exercise is going to be the magic cure to a lot of these things. And like I said, even if I mean, there's no doubt that endorphins get released, which is the pleasure center of the brain during exercise. Even though I got to be honest, I'm in this world myself. It's tough to convince myself that I'm going to have any kind of pleasure out of the pain that I experience after my exercise. But there are certain chemicals that are secreted during exercise that are beneficial for the brain. Okay, so that, like I said, do we have real great evidence-based medicine that says exercise is the cure to preventing? No, but we do have good data out there that says exercise is good for the brain no matter what function that you have.
Mm-hmm.
Not only that, like we talked about before, where the cognitive decline or Alzheimer's or whatever is not the eventual cause for somebody passing, those other comorbid conditions we need to work just as hard at preventing. So heart disease and diabetes and all those things can be prevented or at least postponed with good diet and exercise.
And you said this word twice now to help me understand. So a comorbid condition is some health condition that can ultimately lead to your death?
Right. Comorbid condition is you can probably lump it all into one thing called anything that your doctor would want you to take medication for. How about that? So your diabetes, your hypertension, your cholesterol, and all that kind of stuff.
So something, if left untreated, will result in death or accelerate death.
Correct.
And then you said with dementia doesn't kill, but something else.
Right.
Good.
Right.
Okay. In terms of medical treatments, you said earlier to be cautious as to how you're treating yourself so you don't have drug-to-drug interaction. So just big picture in terms of options medically to treat cognitive decline. So that you're trying to prevent, you're trying to delay, but you still determine that you have it by talking with the physician who's measured and determined what sort of treatments then do exist.
Yeah. The big two, like we talked about before, were the Aricept and Namenda that are out there on the market at this point in time. Both relatively benign medications, one probably more so than the other. There are side effects associated with them. You got to watch somebody's bowel function. You got to watch for lightheadedness and dizziness. Keep in mind that what last thing you want is to put a medication on an aging person because of cognitive decline, and it makes them dizzy to the point where it increases the risk of fall. Because then that fall ends up being more traumatic than anything else, ends up in a broken hip or something else. So it is a delicate balance. One of the things that I know a lot of us do in medicine is when somebody comes in, we need to kind of weigh what's important, what's not important. I mean, if you have a medication that interacts with one of these, whether it's Aricept or Namenda or whatever that prescribing medication is, you need to kind of weigh back and forth. Okay, is it important to be on the medication that's preventing me from prescribing this other pill? So, like I said, it's a delicate game to play, and like the most frustrating thing about it is people aren't going to see it get better. It's kind of like treating cholesterol. So yeah, you feel fine, you go in to see your doctor, you get your regular physical done, and they find out that your cholesterol is elevated. And you start a medicine, and you're taking a medicine every single day, and you don't see anything changing. You don't feel any different unless you get side effects from the medication with achy pains and that kind of stuff. And consequently, people don't take their medicines the way they should when they don't see a change. These medications are the same way. I've had people come back to me, or even relatives of patients come back to me and say, this medication isn't doing anything. The question is, why are you saying that? Because in that first discussion that you have with the patient before you start medications for this, you need to set that clear boundary that says, it's not that we're taking away or making it better, right? We're trying to prolong progression. And then some people come into the office and say, well, I'm convinced it's really not doing anything. Is it the right thing to do to remove that medication at that point in time to see if progression would happen? So it's a really delicate dance that you're doing in these patients. But it's all about education. That doctor or provider should be educating the family and the patient and the like of those other things we talked about, that we do a several different pronged attack at the dementia rather than just merely relying on the medication to be a miracle, which, like I said, it's not billed to be. It is not billed to be a miracle drug. But like I said, if we can prolong that patient or that loved one from having to go that next step to institutionalized or going to assisted living or going to a nursing facility, if you can prevent that for a couple years, I mean, the quality of the patient's life is dramatically impacted at that point. So, like I said, I'm a firm believer. Once you've started the medication route, you keep it on, because you don't know what it's going to do without it, unless you have a side effect, of course. One other thing I want to bring. Hey, do you want to talk to that?
Well, I just wanted to ask a real brief question. So, if I have a loved one and I think they have the onset of cognitive decline,
yes,
what sort of practitioner should I really be seeking out to go to?
That's a great question. There's several people that are really a big fan of the geriatricians of the world that specialize in elderly medicine. But I got to be honest, in this day and age, I really do think that a primary care provider, all of us can recognize it. All of us know the right testing. Now, as far as treatment, that could be a little bit different, but the diagnosis. So if you see a nurse practitioner in a family practice office, or you see a family doctor in that office, or an internal medicine doctor, or a geriatrician, I mean, they all should be able to pick up and at least start early treatment at that point in time. Now, I do think that there is a little bit of value with going to somebody who sees this type of patient on a routine basis. So if there is a geriatrician in your area, it may be important to do, mostly because they're going to be acutely aware of those medications that have those interactions.
Mm-hmm.
There are certain medications out there that there's a word for them in medicine, but I won't bore you with that. But there's certain medications that in certain age populations we should not be using. Things like medications to assist with sleep. Once somebody gets elderly, it increases the risk of falls and confusion. So you don't want to be on those medications as you get older. Things like medicines we use for anxiety, some of those short-acting medicines that we use really shouldn't be used for the same reason. So like I said, I do think a geriatrician, internal medicine, and like I said, there are family doctors and nurse practitioners that specialize in an older population. I would probably gravitate toward those once medication has been started.
Mm-hmm.
Then the question is there a role in psychiatry, psychology, and all of those in the care of these patients? And I would say it definitely wouldn't hurt. I know that mental health, at least here in York County, for sure, it's not like you can just call up a psychiatrist and next thing you know, you're in seeing them, because we're a little underserved as far as our psychiatry here in the area. But like I said, understand that if there's concerns, there are ways to get second opinions. There are ways to at least have that discussion with the provider that's taking care of them at that time, and say, hey, we have concerns that things are getting worse. Allow that doctor to try to talk you through it and identify what the next steps are. I think that's really important.
Excellent. Well, thank you for that great answer. Okay, so you were going to dive into something else, and you gave me my question opportunity. So commence with the dive, please.
Okay, yeah. The one thing I wanted to bring up, which is a very difficult discussion both in the hospital and out of the hospital, is there is a time when, let's start this way, that a family member recognizes that a loved one is getting slightly more confused, maybe on medications or whatever, and the decision is made that they bring that loved one into their home to care for, to make sure that they don't get hurt, to make sure there's somebody around, or for whatever that reason is. One of the things to bear in mind when you do this is when somebody is home, we'll refer back to that 75-year-old that's living by herself at this point in time. They have a routine, and a routine might be, I wake up at, actually a little older patients will probably wake up at 7 o'clock, 6 o'clock in the morning. They get their breakfast, which is probably the same breakfast every day, whatever it is. They watch the same television, Good Morning America, every day, or whatever that ends up being. They may do little things around the house. They take a nap at 2 o'clock in the afternoon. They wake up, they have their dinner, and then they go to bed. And every day is mapped out pretty much the same way. When you interfere with that, when a loved one comes to live with, let's say, an extended family member at that point in time, it is not unusual for that level of confusion to go up dramatically, especially until they get rooted in that new environment. The bathroom's at a new location, their bed's at a new location, the TV's at a new location. And to a cognitive decline brain, it's very difficult to adjust to those changes. So what you'll see is they'll get really, really confused over. People ask me to put a time frame in it. I wish I knew, but until they start developing normalcy again, it could be a week, it could be several weeks for that to occur. I don't know. The reason why I want to bring this up is, number one, it's a phenomenon that can and will happen, and number two, where I live here at the hospital, it happens a lot. So somebody comes in that at home they've been doing great, okay, whatever great means. They never have any problems, but they come into the hospital and now they're confused like crazy. They're jumping out of bed. They're getting aggressive to the nursing staff or the providers that are here. What I tell people is that could be our window into that diagnosis of dementia, because they were so routed in that normalcy, we've just taken them out of it, and now they're really confused. Guess what? That next step, if let's say we have to take them from the hospital and then put them in temporarily into a nursing facility where they have to go back and live with family, you're changing it again. So now this mind that can't make those changes 2 or 3 different times, and it takes a while to kind of get back into some kind of regular thing. The reason why I bring that up is that in the hospital, it really ends up being a very tenuous situation sometimes, where we have family members that say, quote, "What did you do to my loved one?"
Mm-hmm.
And unless you see it, unless you live it, it's really tough to have that discussion and say, hey, you know what? It's not the medications that we're giving. It's just the fact that maybe she was a little confused at home, and it's just been magnified 100 times. Now, one of the things that I do find fascinating is if you take that patient that was confused here at the hospital and you take them back to their home environment. Let's say they were only in the hospital for 2 or 3 days and they were a little bit confused. You take them home, it may take another day or two, and we typically ask family members to stay with them during that transition. And then all of a sudden they get back to that normalcy again, and things start going really, really well. So you can get back to that level of functioning, but in those cases, it is so important to have that follow-up visit with the family doctor, because here in the hospital, because it is a new environment, we don't really do that cognitive level of testing and make diagnosis of dementia, because there's so many differences in the hospital. Not only that, there's so many new medications, there's so many things going on that we wait for the patient to be home back in their environment and following up with their primary care doctor to have that cognitive testing done again. So at that point in time, they can say, hey, you know what? Okay, there is some dementia that we didn't pick up before. Now's the time to start the medication and get the ball rolling. So that could be an early definer of, hey, somebody that we just didn't recognize. Because I mean, if you go in to see your aging parent once or twice a week, and you go to their house and they're always doing the same thing, they can look very, very normal and talk very normal to you. But like I said, it's all these changes that cause things to happen.
So if I were to break some of this down, one, routines for older individuals are a good thing and can help counteract cognitive decline.
Absolutely.
2, if you should try to bring a loved one in to help them and change their environment, that could make things seem worse for a while, just like a hospital visit could.
Correct.
And then your point surrounding that was testing is often something you should do when you're back to some degree of normalcy to get some real feel as to where things are at that time.
Exactly.
Okay. I do have a question that came in, which is, what if a loved one refuses to recognize that there's a problem?
That is very, very difficult. And I sympathize for whoever put in that question, because it happens all the time. It's one of the things that we see in this population is when independence starts to be threatened, they get very defensive. So somebody that lives at home and somebody starts saying, hey, you know what? I'm not sure it's safe for you to live in that environment anymore because you're getting a little confused pop type of thing. All of a sudden the dukes go up, right? It's nope, I don't have any problem. I don't know what you're talking about. I'm fine. I can continue to drive. I can continue to do all those things that I've done before. And it is not a fun conversation to have. I've heard of people having pretty significant altercations in those settings because of that independence. People in this day and age, they recognize that as those conversations get started, where things end up going. Oh my goodness, they're gonna remove me from my home that I've lived in for the last 50 years, and I'm going either to live with them or they're gonna put me in a home. Is a lot of those discussions, and reasoning can be very difficult. I mean, how do you reason with somebody who has a non-reasonable answer to you, right? But it's one of those things that I think, to me, the answer is we need to start putting the onus back on the providers. Do not try to be a loved one and a caregiver in those situations. Continue to support them and say, hey, I think you need to, I mean, if you have a good relationship, let's say I'm your primary care doctor. If you have a good relationship with Dr. Spangler, you start saying to them, hey, you know what? How about we go in and talk to Dr. Spangler about this issue? Let's see what he can do for us. I mean, we've been seeing Dr. Spangler for the last 20 years. We respect his input. Let's see what he says about it. And like I said, in that instance, you have buy-in. You can both do that. And number two, it brings to attention once you get to the office or wherever that is, that says, hey, we're in a safe space. And now that doctor knows why they're there so they can do the testing to get the answer for you. And like I said, when I did outpatient medicine, it was very common that you would have loved ones that would call in those situations that would say, hey, Dad's getting really kind of nasty at home. I don't really understand why. And I say, hey, you know what? Go ahead and bring them in. I've had people going over to their loved ones' homes, getting me on speakerphone. So that way we could say, hey, Jim, how you doing today? Oh, I'm doing fine. Hey, I haven't seen you for a while. How about you come in and see me in the office? And sometimes, I mean, we're not trying to trick them. That's not the case. But we're trying to get them to see that family member not as an enemy in those situations, but as someone who's genuinely concerned. And like I said, there are things that we can do, things that we can help with to make things a little bit better, or at least stop them from getting any worse. And that's worth its weight in gold. And like I said, I used to tell people, have people blame me. I get blamed for things all the time. And well, that's not to say at home. I probably get blamed at home all the time too. But put it on the provider. That's what we get trained for. Those are the things that we do. Let us be the bad guys in these situations. I think that's really going to be the best for everybody. And like I said, I fear those that families that don't want to have one of those really ugly discussions with a loved one. And the next thing you know, somebody's having a car accident or does get lost. I mean, I've had people that found their loved one driving down in Maryland and elsewhere that they have no idea where they're at. Or even worse, they wander away from home in the middle of a snowstorm or something along those lines. I mean, you hear those horror stories all the time. And that's why we can't be afraid of those. Keep in mind that things like Alzheimer's dementia, as much as I hate to admit it, it does seem to pass along generation to generation. It may skip generations, but like I said, if you had your father's mother had dementia and you start seeing these things, it should key you to an even earlier discussion to be had, because a lot of people, if you went through, let's point out Alzheimer's type dementia, if you've been through a loved one who actually had Alzheimer's, the last thing in the world you want as you're getting older is to have that kind of experience yourself, right? Where you don't recognize your loved ones, where you have to be in institutionalized because you can't take care of yourself anymore, because you don't remember to bathe, you don't remember to eat, you don't remember to do all those things that we're supposed to do. And like I said, it's all about that. Got to act on it early. And like we chuckled about before, I mean, we're all losing our keys and we say, oh my goodness, is that a senior moment? Am I starting to lose things and trying to do some of, Jeff, what we said before of putting our keys in the same spot every day. Maybe it's just that easy. Maybe I'm just being careless and I need to start doing something. My wife and I have a joke at home with the dog's leash. I put it the same spot so I know where to get it every time. I feel like I'm hunting all over the house for the leash when my wife does it. But that's just because I want to know where these things are. And then I can't find it, and then I'm like, oh my goodness, am I having problems? But like I said, there's little things we can do that bring us back. So those are just little examples. But if they become repetitive or they get worse, that's when we need to really kind of watch out. Hopefully I answered the question that was posed.
I think you did. I know that in our prior episodes, you spoke specifically about having conversations with loved ones. And that, in fact, is a theme that has arisen in nearly every interview I've done so far, is you should have a conversation about the topic. So in this case, you said, have the discussion. You said rely on the healthcare provider if you need to, blame the provider. And as you were talking, it reminded me that if you could go to your general practitioner and do that on a regular basis, that creates that interaction point where you can start to have the discussion with the provider. And then I heard some benefits to doing it that maybe somebody with the onset may understand, maybe not, but one would be that any sort of recognition of an issue could allow for treatment that could delay progression.
Yep.
That treatment for the issue could avoid another thing happening that would really be detrimental to their health. So I heard a few different embedded benefits to the discussion and using your provider.
Absolutely. Absolutely. That early discussion is so vitally important, because, I mean, it's very difficult. I mean, in past sessions, we've talked about somebody being on a ventilator and those kind of things where they can't answer. This is even harder. This is a person who walks and talks and looks very normal to anybody that's around, but simply cannot put one and one together in those situations. And having those discussions about, well, what do you want to do? Remember how your mom was. What would you want done in those circumstances when, if you get to that point? And like I said, having that discussion early and often is very important. And I know there's a bunch of people out there that don't know their family history very well. This is one of those situations where it's kind of important to know that. I mean, it's tough if we go back to the generation of our grandparents, they didn't know this stuff, right? That your great grandma had an early cognitive decline. Nobody knew that. Everybody just thought she was going a little wacky when she was getting old, right? I mean, she was a little different, and we did have to watch her because she would do some strange things. Well, we know what that is now. So people now know, hey, you know what? Your great grandmom had early onset dementia at age 50. And we need to be able to pass that down generation to generation, because we know that there is some tie there from generation to generation. Whether it skips a generation, okay, fine, but it may be coming back at some point in time that we need to be aware. And like I said, if we have those discussions early and often, we can make the appropriate, whether it's documentation, whether it's having those discussions on who your power of attorney is going to be, those kind of things early, so that way we're not stuck having to make those decisions on our own without input from our loved one.
Thank you, Doc. Well, I do, and I did seminars just last week on estate planning. One of the slides says that we all get older and die.
Yep.
And we often all need help. So that really is a reason to have these conversations. And we've talked about important documents related to this. Our discussion is really focused on that advanced healthcare directive that include the healthcare power of attorney and the living will. I also counsel people on a power of attorney, which just allows somebody to make medical or not medical, make financial or legal decisions for them. And then I do talk a lot about the will itself, which dictates what happens. So I agree with you on the conversations. And then for my part as a professional, I help with those documents, because the conversations and the documents can protect you. They can protect your loved ones. They can make things better than they would other be and help avoid problems.
Absolutely. Couldn't have said it better.
Well, this has been another outstanding session. Is there any other tips or any other thoughts you want to offer on cognitive decline today?
The only thing, like I said, it's not adding anything. It's just repeating it one more time, is that we establish primary care physicians for a reason. Don't try to do it on your own. Go to see them. Let them help you through the process. Like I said, we're all trained in how to deal with these cognitive declines. If they don't feel overly comfortable, they'll find a way to navigate the system for you, because the system can be very, very complex. And there's a lot of really bad information out there. So rely on your healthcare providers to help you through.
Excellent. Well, thank you for that recap, Doctor. And thank you once again for your insight, your professionalism, the means by which you're explaining these topics. You're well-spoken. Good luck finding your keys in the dog leash. And we won't dive into whether or not you get in trouble with the officer at home and where they've driven testify, because I understand how that can be. So
absolutely.
Thank you so much for your time, and we'll call this an episode and sign off. So thank you.
Thank you very much.